Maleeha. I'm one of the Obs&Gynae registrars working in the UK. The Hishta got in touch with me to cover gynae emergencies today. So I'll try and make it interactive. Please do chip in, ask questions as we go. Okay? So we'll start off with a case so that we have something to work around. So you have a 24-year-old female. She's presented to the emergency department. She's collapsed. She's had some vaginal bleeding, and she has pain in her right iliac fossa. Do you want to shout out your differentials for this patient?
Is she pregnant? By the history?
Yeah, so that's one of the differentials. So if she's pregnant, what are we worried about?
If it's in the early pregnancy and it's the bleeding of the early pregnancy, I could think about abortion or ectopic pregnancy, and also I could think about GID.
Okay.
Yes.
Good. So if she's not pregnant, so someone else is mentioning in the chat about potential molar pregnancy. And what about if she's not pregnant? Any other conditions you would have in your list of differentials?
It could be a menstruation or not.
But she's collapsed in A&E.
Yes.
So
yes. Okay. So
hopefully not every month.
yes.
So anything else at all in your differentials? So adenomyosis would cause severe pain during a period. Okay, that's great. Let's carry on then. So what is really, really good is when you divide, and that was the first question you asked, was it pregnancy or not pregnant? Because it's really good when you're thinking about gynae, particularly in this emergency situation, you want to know, it completely changes kind of all of the differentials that you're going to think about. Is it pregnancy related? Could it be an ectopic pregnancy? Could this be a miscarriage? Okay, which we'll talk about. And then non-pregnancy related, could this be an ovarian cyst accident? We'll talk about all of these conditions. Could this be ovarian torsion? And then remember, although she's a female, and if you have a female who's collapsed, unless proven otherwise, you think about an ectopic pregnancy. But remember non-gynecological causes as well. So we also want to think about GI problems, so appendicitis, urological things. So she got kidney stones and happens to be on her period at the same time. So we keep our mind open and we slowly narrow down. Someone mentioned here about leiomyoma. So those are fibroids. In itself, I would not routinely expect someone to come in collapse due to a fibroid. However, you can have kind of degeneration within fibroids, and that can cause severe pain as well. It would be amongst your list of differentials, but a bit lower down. So, pregnant, non-pregnant, and the emergencies that we're going to think about today, we have ectopic and miscarriage. And we think about hyperemesis in pregnancy as well. That's a common thing you'd see in the emergency department. And then non-pregnant, you have ovarian cyst accident. So this is where the ovary could twist on itself and it can cause torsion. And if not treated, it causes the ovary to die. You can have rupture of a cyst. You can have bleeding into a cyst. You can also have heavy menstrual bleeding, which we'll talk about, one of the causes of which can be leiomyomas, fibroids. And then endometriosis is another situation where you can have some women in severe pain. But today we're going to focus on these four because we're limited on time. So let's go back to our lady. So she's come in, she's 24 years old. I want you to put just your medical hats on. What is the first step in your management? Mohammed is right onto it. ABC, really, really important. Not to forget that you might be treating a gynecological condition, but your basic resuscitation is always the same. So you assess the airway, you look at her breathing. give oxygen if the sats are low, if needed. Look at her capillary refill, look at her heart rate, her blood pressure, and accordingly you may need to give fluid. Stat, obviously, if she's collapsed in A&E, the likelihood is you'll be giving both of these things. And then you think about exposure and taking things from there. Okay. So I just don't want you to forget, A, B, C, D should, every speciality is where you start from, okay? So I want you now, so suppose we've now like stabilized the woman and she's fine. What questions do you think we should be asking this patient to determine what condition she may have, or what has caused, or what pathology she have? What questions, what history do you want from her? Feel free to unmute, or you can write in the chat. You want to know about history of trauma? Mm-hmm. So you've got a lady, she's collapsed, she's got pain, she's got bleeding.
I would ask, when does this start?
Yes.
And the duration.
Good, excellent. When did it start? How long has it been going on for? Fantastic. What else do you want to know? Okay, let me go through. I want you to think about it in chunks. So someone's mentioned here about drug history, past medical history, all really important things. So start with one thing at a time. Let's start with her bleeding. All right, we want to know, when did it start? How long has it been there for? How much has she bled? The amount of bleeding will send you to a different diagnosis. So suppose at this point you do not have a urine pregnancy test. You don't know if this patient is pregnant. Let's just say, for example, you know, if she's got scanty, dark, little bleeding, then you're thinking more along the lines of potentially an ectopic pregnancy. If she has very heavy bleeding, passing clots, you're not thinking of an ectopic as much. You were thinking more along the lines of miscarriage. Okay, we'll talk about all of this in due course. And then separate into the next. So she's got bleeding, you find out about that. And then think, okay, her next issue is pain. Let's find out a bit more about the pain. So is the pain with the bleeding, before the bleeding, after the bleeding? When was it? And remember, I'm sure you've heard of Socrates to find out about the nature of pain. So the site, where is the pain? Is it on the right side? Is it on the left side? This will help you if it ends up being an ectopic pregnancy. Then you can look at the right, left. You can help you to work things out. The onset, was it sudden, or has she had cramping, and that's gotten really bad? What's the character? Is it coming and going? Is it constant? Does the pain spread anywhere? Now, this is really important, because if you have a patient with an ectopic pregnancy, it really helps you to assess what kind of severity you might be dealing with if she's having shoulder tip pain. Now, this pain is referred pain. So if she has an ectopic pregnancy, which has ruptured, and there is bleeding intra-abdominally, that pain, that blood can irritate the diaphragm and cause referred pain to the shoulder. So again, important to ask. Exactly. Someone's mentioning the phrenic nerve there. And then you ask about severity. That will help you to make an assessment how much pain relief you need to give. And then ask about other symptoms. You know, has she been feeling dizzy before? And obviously we know she's come in collapse. You can also ask, has she had diarrhea suddenly and out of the blue? Because again, if she's got if she's got blood within the abdominal cavity, it can irritate the GI tract as well, and then you can get diarrhea as well. Okay. And then now those are your generic questions you're going to ask. And now remember, you're thinking of your gynae issues here. So you then think about the menstrual cycle. When was the first day of her last period? Really important. If her period was a week ago, her LMP was 1 week ago, she's not going to be pregnant. So really important. But obviously, if that LMP was 6 weeks ago and she has a regular cycle, then you're thinking, okay, this woman could be pregnant. So But with that, it's really important to ask how regular the cycles are. Because if a woman normally has quite delayed periods, so she normally has a 6 to 8 week cycle, then you'll be less inclined to thinking about pregnancy. And then ask, was she planning a pregnancy? And if she's carried out a test or anything like that, if relevant. And then remember, within Obs&Gynae, your previous history of conditions will often guide you about risk of future conditions. So has she previously had a miscarriage? Has she previously had an ectopic pregnancy? If she has a history of multiple miscarriages, then you'll start to risk stratify her that this may be going towards a miscarriage. If she's had one miscarriage, that doesn't make her at higher risk of having another miscarriage, not significantly higher anyway. Okay, I take that back. There is some history of if you had a previous miscarriage, then obviously depending on the cause. And then if you think about ectopic pregnancies, the risk increases significantly if she's had one previous ectopic, and having a future one will be increased. And then you want to know about her previous gynae history, any history of sexually transmitted infections, is she on any contraception? All of this will help and guide you. Okay, you're going to go on to examine her now. So we've talked about A, B, C, D, okay? So generally, you want to see, has she got pallor? Is she tachycardic? Is she hypertensive? And then specifically, you want to look at her tummy, and you want to be looking for tenderness and guarding. And what you're worried about is potential intraperitoneal bleeding due to a ruptured ectopic pregnancy. You would then also examine the uterus, and you want to kind of look at the size of the uterus, and if it's in keeping with what is suggested of her week's pregnancy, her gestation, if you know that she is pregnant, and if it's much smaller than you would expect, then you want to think about, do we have an intrauterine pregnancy here at all? Is it misplaced like an ectopic, or has it been lost like a miscarriage? And then with a pelvic examination, obviously examine her fully. You want to see, has she got a heavily soaked pad? Is she actively bleeding? Is there blood trickling? You would do a speculum examination. You want to look at the cervical os. And with this, if the os is closed, there can still potentially be a miscarriage there, what we call is a threatened miscarriage. So there is a threat to the pregnancy. If the os is open, then we're thinking about an inevitable miscarriage. I will go through these terms in shortly as well. Okay, this is to give you an overview. And so with pelvic examination, obviously we do a bimanual examination as well. And when you do that, you want to see if there is cervical excitation at the cervical os, and that may indicate an ectopic pregnancy. Okay, a lot of information, okay? So investigations, what investigations do you want to do on this woman? HCG, okay, fantastic. So you want to start off with just urine HCG to determine pregnancy, yep. What else do we want? Yeah, we want to know her blood group, really important. She's bleeding, and her rhesus status as well, so that if she is requiring blood, we can give that to her. What else do we want to know? A full blood count, really important to try and work out, how much bleeding has she had? Is she compromised? Does she need to be given blood? And you want to visualize. How are you going to visualize? Someone said coagulation profile. If she's bleeding heavily, then yes, we would do that as well. How are you going to visualize and work out if this is a positive pregnancy test, for example? You want to do an ultrasound as well, really important. Those are your main things. A urine HCG, do some bloods, your full blood count, your group and save, and you would think about doing a blood HCG. That would help guide you in your management going forwards, and then ultrasound scans. So this would be transvaginal, ideally. You can visualize things much better, or transabdominal otherwise. Now, I'd like to introduce you to the concept of blood HCG, because this is really helpful when you're trying to make a diagnosis and determine particularly if you don't have immediate access to ultrasound as well, to try and work out what you're dealing with within a pregnancy. If you have a positive HCG, this woman is pregnant. We know that much. Now, the HCG, there is no point repeating it after 12 hours, after 24 hours, after 36 hours. No, you repeat it after 48 hours, because we have evidence base for what would be expected to happen to the HCG in that process. So a HCG 48 hours apart, if the HCG has doubled, you are very likely to be dealing with an intrauterine pregnancy. If it's halved or less, it's very likely that you're dealing with a miscarriage. If there is a suboptimal rise, so between 50 to 100% rise, so usually we're looking at kind of a 66% rise, that tends to suggest that this may be an ectopic pregnancy, okay? And you can imagine that this would in part be because the pregnancy is not implanted in the uterus and isn't able to grow as well. It doesn't have the support that it would need if it's in the tube, for example. And obviously, if the HCG is increasing very significantly, A, it could be a kind of a twin pregnancy you're dealing with, or a multiple pregnancy, but B, gestational trophoblastic disease, a molar pregnancy potentially as well. And a number that is really important for you to know is 1500. When you have a HCG of 1500, you would expect to see this pregnancy on ultrasound. Okay, so if you do a HCG and you're suspecting an ectopic pregnancy and it's only 600 or 800 and you don't see anything on scan, remember that you do not expect to see a normal pregnancy in the right place, an intrauterine pregnancy, until the HCG is much higher. So at 800, even if the pregnancy is in the right place, you would not be able to see an ultrasound. That does not mean it is an ectopic pregnancy. It is then likely to be or what we call, we label it as a pregnancy of unknown location. And we'll talk about that, PUL. Right, let's go back to our case. So our 24-year-old female who's collapsed, bleeding, right iliac fossa pain. So she's stabilized in A&E. Mohammed's done a brilliant ABC approach on her, okay? And she tells you she has scanty bleeding. It's sudden onset in the right iliac fossa. There's no radiation of the pain. She's had some very mild cramping over the past week. Her LMP was 6 weeks ago. She's known history of previous PID, pelvic inflammatory disease. She has one child previously delivered by cesarean section. And she smokes 5 cigarettes a day. What is your primary differential here? What is the first thing you want to exclude?
Ectopic pregnancy.
Excellent. An ectopic pregnancy, exactly. I made it quite easy for you, but you should feel proud of yourself because that's the first thing you want to exclude. So let's talk about ectopic pregnancies. So this is where you have an embryo that implants outside of the uterine cavity, yeah? So instead of implanting within the endometrium, it's implanted outside. Now, most of them, 95%, is tubal ectopic, so they're in the fallopian tube. You can also have ovarian ectopics, cervical ectopics, abdominal ectopic pregnancies. In the UK, the incidence is about 1 in 1,000. Risk factors, previous ectopic pregnancy is a big risk factor. Previous pelvic inflammatory disease, because what you can imagine is if this whole pelvis has been inflamed. There may well be adhesions and things that will make this prone to developing an ectopic pregnancy. Previous tubal or pelvic surgery, smoking increases your risk factors. But 1/3 of patients have no risk factor. Okay, so always keep it in mind. And then 2 crucial investigations for your management is your 48-hour HCG and a transvaginal ultrasound scan, ideally. And with your transvaginal ultrasound scan, if you can't see anything, you give a diagnosis of pregnancy of unknown location, PUL. This could be because it's too early and you just can't see it because the embryo is just not big enough. Or she's bled heavily and it's miscarried, okay? Or it's an ectopic pregnancy. So you use the HCG because it will help you, one, to determine if you think it's an ectopic, but it will also help you to see, once you have diagnosed an ectopic, if the HCG starts to fall, then it may well be that actually this is falling and resolving itself. We do not need to intervene, okay? So PULs, you do your HCG 48 hours apart, greater than 63% increase, so doubling, likely intrauterine, you would do another scan in 7 to 14 days, or earlier if the HCG is more than 1500. If there is a drop of greater than 50%, the pregnancy is unlikely to continue, and she can do a urine pregnancy test in 14 days. And if you have a value between 50 to 63%, she needs to be reviewed as a potential ectopic pregnancy. Okay, now, if you've got your diagnosis, then you can see here, this is a tubal ectopic pregnancy. It's unruptured, so it's within the tube still. But if this was to rupture, you can imagine how much she would bleed. And obviously it's very thin, the tube. And that is why if someone's coming in collapsed, you're more worried about a ruptured ectopic pregnancy, because this in itself would, it may cause her pain and discomfort, but you wouldn't expect this to cause her to collapse in itself. Okay, so you can do conservative management, expectant management. This would be if she's stable, she's free of pain, and on ultrasound it's less than 35 millimeters, there's no fetal heart present, and the HCG is less than 1000. Okay, you need to have those criteria to then do conservative expectant management. She needs to be able to return for follow-up, and you would repeat the HCG on days 2, 4, and 7, and you'd expect them to progressively decrease. Okay, and then you continue repeating it until you have a negative result. And then medical management is with methotrexate. This is, again, the criteria for this. She shouldn't be in significant amounts of pain. It should be unruptured, less than 35 millimeters without an FH. HCG should be less than 1500. And there should be no intrauterine pregnancy. Now, by this, what we mean is you have a condition, what is called a heterotropic pregnancy, whereby there is a pregnancy in the tube and there's a second pregnancy in the uterus as well, intrauterine pregnancy. It's not very common, but it does happen. And if you're giving methotrexate, you're giving this as an injection. And so if there was to be a pregnancy in the uterus, this would also then be terminated. Okay? She needs to be able to return to follow up. And so we do her blood results a bit later this time. We do it on day 4 and day 7, and then once weekly until negative. And the reason for this is you initially get a flare of the HCG going up before it goes down. Okay? And there's no difference between these 2 methods of management in terms of the risk of rupture, the rate of the ectopics ending naturally, and the need for potential additional treatment, so patients needing to go for surgery, for example. Okay? And then finally, we have the surgical management. So if this patient is in significant pain, so our lady, she came in significant pain, greater than 35 millimeter ectopic, if there's a fetal heart present, or if the HCG is greater than 5,000, then you go for surgical management. Now, this involves going in either laparoscopically, keyhole surgery, or open surgery, and you would do, there's two options. You can either do a salpingectomy. This is where you make an incision and remove the ectopic pregnancy, but you don't remove the whole tube. Or you would do a I said that wrong. Salpingectomy is when we remove the whole tube, okay? And the alternative is a salpingotomy, whereby we go in and remove the ectopic, okay? Now, the decision between the two will depend often on the patient's fertility wishes. So if she has previously had difficulty in conceiving, then it may be that she would have difficulty going forwards. And for this reason, we do a salpingotomy, and we don't take away a tube, because that will obviously reduce her fertility a little, somewhat, not completely, of course, because we know that one tube is more than sufficient to conceive with. But if she has no previous risk factors for infertility, then we would aim to just remove the tube, because doing a salpingotomy means that there is still a risk, obviously, of her having a future ectopic, and there is a 1/5 risk of her needing further treatment with a salpingotomy. It may be that she needs methotrexate, or she may need a salpingectomy. Okay? Okay, now let's go back to our case. So our 24-year-old lady, she's collapsed, she's bleeding, but she's complaining generally. Oh, yes. So someone's asking, well spotted, what do you do between 1,500 and 5,000? This would depend on the patient and the situation. So between those values, you would weigh up between medical and surgical, depending on the pain, the size of the pregnancy, and the exact HCG value. Okay. So this lady then, she's 24-year-old female, presents to A&E with collapse, bleeding, and abdominal pain. She's stabilized. She's passed 1 liter of heavy, fresh bleeding with large clots at home. She has extreme cramping pain. Her LMP was 6 weeks ago, no previous pregnancy, and she also smokes. Differential, primary differential here.
Abortion, mainly.
Yeah, miscarriage, exactly. So we're thinking about whether she is having a miscarriage here, and that's because of the heavy bleeding. But you can sometimes have women with an ectopic who do have a lot of bleeding as well. But your primary differential that you're working with here would be a miscarriage. So miscarriage, so it occurs in 10 to 20% of clinical pregnancies. Risk factors, maternal age. And in terms of age, I'll just show you here the risk of your miscarriage. Yes, increases quite significantly, kind of 34 onwards. So 30 to 34, is 15%, then 35 to 40, looking at 25%. Above 40, it goes to 50% risk of miscarriage. Above 45, your risk of miscarriage is 93%. So age is an important factor. Illness, trauma, there are some medications, and locally, if there are fibroids that distort the endometrial cavity, if there's a malformation of the uterus, if there's incompetency of the cervix, if there's a chromosomal abnormality, and this accounts for about 60% of miscarriages. And the number of previous miscarriages, it is important, because the risk of a further miscarriage increases the more losses you have. Okay, so after 3 consecutive pregnancy losses, your risk is about 40% of having another miscarriage. Okay, what we call recurrent miscarriage, when they've had 3 or more. And a previous live birth does not mean that a woman can't go on to have recurrent miscarriage. So I want to just talk through this breakdown, because you want to be able to make a diagnosis of the type of miscarriages a patient's having. So within miscarriage, you have spontaneous miscarriages. This can be threatened or inevitable. Okay, let's talk about the difference of these two. So with a threatened miscarriage, you're expecting some bleeding. It's usually minimal, usually mild pain or no pain. The uterus is about the size of expected of the gestation, and the cervix is closed, and the scan shows a viable fetus. So you do a scan, there's an FH, and she's had some bleeding, and the cervix is closed. That's what we call a threatened miscarriage. This pregnancy may go on to fully miscarry. It may go on to continue. The alternative to that is inevitable miscarriage, where there's been quite significant bleeding, significant pain. The uterus is equal to the dates. The cervix may be opened, and the fetus may or may not have an FH. But the crucial thing here is about the cervix being open, and cervical change, because once the cervix starts to open, it's not going to close in early pregnancy unless it's past the fetus. Okay, so if you have an inevitable miscarriage, so the cervix is open, this can be complete or incomplete. So if it's incomplete, she may be having ongoing severe pain like our patient is, and heavy vaginal loss. The uterus is getting smaller, the os is open, and you may well see products of conception within the cervical os that need to be removed. The patient is in distress. Now, this compares with a complete miscarriage. This is when essentially it's past, it's all past. She's had severe pain earlier, severe bleeding, but now it's all settled down. The pain is settled, the bleeding is settled. The os is usually still open because it's just past all of the products. And in this situation, when you scan, the uterine cavity is empty. Now, it's important just to note here that when you diagnose a complete miscarriage, if they've not had any scan this pregnancy, they should still be monitored, because unless you've had a scan during the pregnancy, you can't say for sure that this was a miscarriage, because you need to have seen the pregnancy and then for it to have gone on scan, and then you know this is a complete miscarriage. Because if your only scan is an empty uterus, then it could be that this is an ectopic pregnancy, which is why you're not seeing anything from the scan. So in those situations, we would do a HCG to check the value and monitor if need be. Bear with me. Okay, I'm sorry. What's happened here? Sorry, bear with me, guys. This is disconnected for some reason. Okay. I'm sorry about that. Where are we? Okay. Sorry about that. So yes, and the third is a recurrent miscarriage, which is essentially where a patient has had repeated miscarriages. Now, previously, this used to be thought of as 3 miscarriages or more, and yes, they should be consecutive, but the guidance is now being updated on this. Okay, so your management of miscarriage, conservative, medical, surgical, whenever you're talking about management or explaining it to someone, it's always good to structure your answer. So conservative management is what we call expectant management, where we watch and wait. And you would only do this if there isn't a high risk of hemorrhage. She hasn't got a history of significant heavy bleeding in the past with a miscarriage. And she hasn't got any history of coagulopathy. There's no evidence of infection. Yeah. And then if she has bleeding and pain, which suggests she's had a miscarriage, we would then advise her to return after 3 weeks, to do a urine pregnancy test after 3 weeks. And if it's positive, then she'd need to be seen for review. If in that period of time, when you're watching and waiting for about 7 to 14 days, if there's no bleeding or there's no pain, or the bleeding and pain is continuing after that period of time, then we need to bring her in for an ultrasound scan. Okay. And then if you have a missed miscarriage or an incomplete miscarriage, so a missed miscarriage is when you scan and unfortunately the fetal heart is not present, but bleeding has not started, or there's an incomplete miscarriage, one of the alternative options is medical management. So this is where we give oral or vaginal misoprostol. The dose will depend on if it's a missed or kind of incomplete miscarriage. You want to give pain relief. You want to give anti-sickness. It's a difficult thing to go through. And then obviously advise on the process and the bleeding. And then you would advise, we would expect, so 80% of women within 24 hours start to expel the pregnancy. So we would normally offer to call them after 24 hours to see that there has been bleeding and passing of the pregnancy tissue. You would advise the woman to take a pregnancy test after 3 weeks. And again, if it's positive, we need to review her, or if there's worsening symptoms, then she needs to return and be reviewed. And the third option is surgical management. Now, this could be, if there's excessive bleeding. So like our woman, she's coming in with very heavy bleeding. If there's hemodynamic instability, evidence of infected retained tissue, or if you're worried about a potential molar pregnancy. Then you would offer surgical management, and this can take 2 routes. Manual vacuum aspiration, MVA. This is done under local anesthetic, where a suction curette is put into the uterus and the pregnancy tissue removed, and surgical evacuation, where it's done under general anesthetic. Okay. It's important to reassure the woman, especially if it's her first miscarriage. We know that 20% of pregnancies will miscarry, unfortunately. So reassurance is really important that, she has a very high likelihood, if it's her first miscarriage, of having a normal, ongoing, healthy pregnancy in the future. Optimize any risk factors, so if she smokes or on any medication that can be stopped. It's important to safety net her that if she has heavy bleeding or foul-smelling discharge, and you're worried about infection, to come back. Discuss contraception and future fertility. We normally advise her to allow 1 period so that her dates reset, essentially, and psychological support as well. Okay, let's go back to our lady now. So she's our 24-year-old female. She's gone through a lot, bless her. So she presents to the emergency department. She's collapsed and she's got severe pain this time. Okay. She's stabilized in A&E. She had sudden onset pain for the last 3 hours, 1 episode of vomiting. Her LMP was only 2 weeks ago. No previous pregnancies. She's known to have a 5-centimeter dermoid cyst, for which she's awaiting surgery. What is your differential? Okay, PCOS. So PCOS, polycystic ovarian syndrome, does not usually give you pain. The triad you're thinking about with polycystic ovaries is, patients who have hyperandrogenism. So they may have facial hair, acne, kind of sweating. And you are thinking about oligomenorrhea, so infrequent periods, and you're thinking potentially on their bloods, you would see a biochemical abnormality with an increased testosterone, an increase in the LH to FSH ratio. And the 4th thing is on scan, you would see lots of follicles in the ovary. And if you have it's called Rotterdam's criteria. You have a certain number of each of those then you would be diagnosed with polycystic ovarian syndrome. It would not cause this kind of an emergency situation usually. So someone's saying potentially molar pregnancy. So remember, this woman is not pregnant. Her period was 2 weeks ago. So I want you to go in your diagram. I want you to go onto the other side of in your algorithm and think non-pregnant. What potential things could this be? This tends to be a bit harder because it's not so common. So yeah, and so it's an ovarian cyst. So a 5 centimeter cyst normally can cause some discomfort and pain. But if it's causing severe pain and she's collapsed and it's sudden onset, you're thinking about an ovarian cyst accident. So let's talk about that. So we're coming to this side of our algorithm now. She's not pregnant, ovarian cyst accident, okay? Now this can take 3 primary forms, okay? You can have rupture, where the cyst ruptures. It doesn't have to be blood inside it. It can just be the cyst content, okay? You can have hemorrhage into the cyst, or a cyst that has had hemorrhage can also rupture, and then you can have something called a hemorrhagic cyst. Or the other thing to think about, and an important one to exclude, is ovarian torsion, which is where the cyst within the ovary twists, cause the whole ovary to twist on itself in what's called ovarian torsion. Now, this is a surgical emergency because the twisting causes the blood supply to the ovary to be compromised, and therefore you can have infarction of the ovary, okay? So with a ruptured cyst, what you would expect is intense, sudden onset pain. She may be known to have an ovarian cyst. And if it was a big cyst, then it may no longer be palpable on examination. On the ultrasound scan, you would no longer see a cyst on the ovary, but you would see fluid in the pouch of Douglas because it's ruptured. Yeah. Now, normally with an ovarian cyst rupture, it would have be managed conservatively. We would normally give them pain relief and watch and see how they go, and normally it would self-resolve. Hemorrhage, and this, as I say, it could be into the cyst, bleeding into the cyst, or a cyst can rupture and you can have hemorrhage with it, and there's bleeding into the peritoneal cavity. And you can imagine that could be quite significant bleeding, and it can cause them to develop hypovolemic shock. And so it's important that they're stabilized if that is the case, and they may well need to be taken for a diagnostic laparoscopy into theatre. More often than not, however, they don't usually bleed quite so heavily. It may well be that there's some bleeding and you see that in the pouch of Douglas, and again, you manage it conservatively. This time you're also thinking about antibiotics if there's blood there, which is prone to infection. Okay. And then we're thinking about ovarian torsion. This is where you would expect severe acute lower abdominal pain. She may well have nausea and vomiting associated with it. If you examine her, you may well be able to feel the mass. And on the ultrasound scan, you would expect to see a cyst, usually within the ovary. Ovaries don't usually twist just by themselves. Usually they have been made heavy by a cyst, which can cause the twisting. Someone mentions about a Doppler ultrasound scan, which can be done to see about the blood supply. And your management is surgical intervention to prevent infarction. And normally we would untwist the ovary and see, because ovaries often recover quite well, even if they do look blue when you go in initially, you can untwist them. And then they often do recover. Obviously, if it's been a while since the pain and the torsion, it may well have infarcted, and then you would do an oophorectomy and remove. Okay, so here's an example here. So this, you would have the uterus here, the tube coming here, and here you have your ovary with a cyst in it, which would be twisting on itself. And so, at this point, it doesn't look like it's infarcted. You would untwist this and would then hope for the blood supply to recover. And then at a future date, you'd want to go and manage the cyst with a cystectomy, hopefully. Okay. Okay, and we'll just go on. I don't have a case for this one, but we will just briefly also talk about heavy menstrual bleeding. So, within the UK, once a week, pretty much in most hospitals, or once every 2 weeks, we would have someone admitted with a hemoglobin of 50 or 60 due to very heavy menstrual bleeding. Okay, so heavy menstrual bleeding, previously, people used to define it as 80 mils of blood, but no, we no longer do that. We define as excessive menstrual loss, which interferes with a woman's physical, social, emotional, or material quality of life. Okay, so bleeding is slightly different in gynecology because menstrual bleeding is a normal part of a woman's healthy health, but it is when that bleeding becomes excessive and affects her quality of life that we define it as heavy menstrual bleeding, and then think about investigation and treatment. This differs from rectal bleeding, for example. That is abnormal. So all of that would need to be investigated to determine what the cause is, and so that is a red flag symptom for concern about cancer and that pathway. Whereas for us, we investigate bleeding usually to manage the impact on the quality of life of women. Okay, so what conditions? Can you think of any conditions that cause abnormal uterine bleeding? So someone before mentioned leiomyomas, adenomyosis, endometriosis. So think of endometriosis more about pain. The triad that we normally think about with endometriosis is chronic pelvic pain, infertility, and dyspareunia. Okay, that's so coagulopathy is also a potential cause. Excellent.
Thyrotoxicosis, or sorry, hypothyroidism.
Yeah, so if they have other biochemical abnormalities, certainly. Tumor, so endometrial cancer, yeah. So what I'd like to introduce you to is the Federation of International kind of Gynecologists and Obstetricians. They have an acronym that we use. So PALM and then COIN to try and work out. So these are your structural abnormalities, and these are more kind of biochemical or endocrine and biochemical. Okay, so polyps is one. So this is outgrowths of the endometrium. Okay, that can cause bleeding. Adenomyosis. This is where you have endometrial cells that migrate into the myometrium. Okay, I'll show you a picture in a moment. But because they have migrated into the myometrium, they don't then have a pathway when they bleed responding to the hormones of pregnancy. They can't then bleed out. And so you're bleeding into the myometrium, which causes significant pain as well as heavy bleeding. And leiomyomas are fibroids, a very, very common condition in women, particularly women of Black and Asian ethnicities, malignancy. When it comes to leiomyomas, fibroids, they can be divided up, and we'll talk about the different types, okay? And then COIN, you're thinking about coagulopathy, someone mentioned, well done. Ovulatory dysfunction. So if you have PCOS, that can cause you to have abnormal uterine bleeding. Endometrial pathology. So within endometrial pathology, you can think about endometrial hyperplasia. Now, this is a condition where it's a precancerous condition, which can be divided into atypical hyperplasia and non-atypical hyperplasia. Now, it's important that that difference is determined, and it's determined by histology, because if you have endometrial hyperplasia and your risk of having cancer, concurrent cancer, is 20 to 25%. So endometrial hyperplasia is treated very similar to early stage endometrial cancer with a hysterectomy. If you have endometrial hyperplasia without atypia, the risk is very different. Your risk of developing cancer after 20 years is 5%. And so the treatment of that is very different. We don't subject them to surgery and the risk of surgery. Instead, we offer them progesterone therapy, usually in the form of something called a Mirena coil, where they have local progesterone therapy inside the womb. Okay, and other causes, iatrogenic. So if a patient has developed a thrombosis, a DVT, then there is a risk, then they would be on blood thinners, and that could then lead to heavy bleeding. And not yet classified is essentially something to remember, because if a woman has abnormal or heavy bleeding, it is to say that although we do not have a cause yet specified for the bleeding, this does not mean you don't have bleeding. We still verify and understand that the woman is having abnormal bleeding and heavy bleeding, but it's just that we will manage it as best we can with generic treatment, but we don't yet have a specific cause. Okay? What do you think this might be? This, just to explain what this picture is, this is at hysteroscopy. This is when you're going in with a long camera into the cervix and heading towards the uterine cavity. Okay, you go in with a camera inside the uterus and you see this. Any guesses what this might be sticking out? So this is a polyp, an endometrial polyp, okay? So you can see here. So in that picture, we were coming up here with a camera and having a look inside. And this is an endometrial polyp, okay? And they can cause bleeding. So we could go in then. That was quite a big one. So we can use polyp forceps, go in, hold on to it, twist, and it usually twists off the base, and then we can pull it out. Sometimes we need to go in with a heated loop and then remove it. Okay, that's a polyp. This is something different. Or you can kind of see from here what it is, but anyone want to hazard a guess what this might be? A fibroid, exactly. So this is the uterus. This is the uterus. These are the tubes and the ovaries here. And this here is a very big fibroid, okay? So your fibroids can be divided into different types, okay? I'm going to show you a simple classification. There is a more detailed classification going from 0 to 7. But in terms of this, I want you to think about is submucosal, intramural, and subserosal, okay? This here would be a subserosal fibroid. Okay, so a subserosal fibroid is under the serosa. And what you can imagine is this kind of fibroid would cause pain as the main symptom. Yeah? And then these can be pedunculated if they have a pedicle underneath. The second thing you can have is intramural fibroids, which are here within the myometrium. Okay, with this, you can have both abdominal pain, distension, but also heavy bleeding as well because they're within the myometrium. And then your third thing that I want you to think about is your submucosal fibroid. So this is within the endometrial cavity here. And here it's pedunculated, it's got a pedicle. And these would classically cause heavy bleeding because they're disrupting the endometrium. Okay. Now this here is adenomyosis. So you have a normal uterus here. Okay, you can see this is an MRI scan above. That's your normal uterus. With adenomyosis, the endometrial glands have gone into the myometrium, causing it to be heterogeneous, enlarging the uterus, and you can sometimes have these little kind of cyst-like spaces where there's bleeding within the myometrium. And so adenomyosis classically causes heavy bleeding, but also significant pain during the period. Okay. In terms of the history, it would be slightly, you would want to get a bit more detail from her. If you're dealing with someone with heavy bleeding, you want to know a bit more about her menstrual history, the amount and timing, is she flooding, frequency and regularity, when did she start her bleeding? So if she has had heavy bleeding all of her life, you want to be thinking, does she have some kind of coagulation problem? Does she also have a history of dental bleeds, for example, bleeding normally easily as well? And then you also want to find out about other intermenstrual bleeding and postcoital bleeding, any associated pain. You want to know about fatigue and lethargy. That will help you to work out what her likely kind of full blood count might be and anything we may need to give her. Contraception to work out is important because it will help you in the management. Because if she is wanting contraception, then you can offer her different treatments to if she is wanting to conceive. And then we have the cervical smear. Obstetric history, we want to know what her family planning plans are. Her past medical history, someone mentioned about thyroid disease, any history of bleeding or clotting disorders. Family history, any family history of endometrial cancer or any other cancers that would put her at higher risk, any bleeding or clotting disorders. We want to know about the impact on her life, okay? To be defined as heavy menstrual bleeding, then we're thinking about impact on the woman's physical, emotional, and social or material life. When you examine, similar, we've kind of covered this before, so I'll just mention here, when you examine the abdomen, you're looking at a pelvic mass. You're thinking about fibroids potentially there. If it's very tender, you're thinking about adenomyosis. And when you describe how big the uterus is, you can talk in terms of weeks pregnant. So this is a likely fibroid uterus, which is about 24 weeks in size. And then you would do a speculum examination and do a bimanual examination, which will help you to see the enlarged uterus and tenderness as well. What symptoms might you expect? So with a polyp, you would normally get intermenstrual abnormal bleeding, adenomyosis, heavy bleeding and pain. Fibroids, you'd get heavy bleeding potentially, or you may get pressure and distension depending on where the fibroid is. If there's malignancy, you're expecting kind of unscheduled bleeding, unresponsive to hormones, and they may have associated risk factors. High BMI is a very important risk factors in endometrial cancer. And then coagulopathy, primary menorrhagia. So from day one, her periods have been very heavy. Family history, dental bleeding. So if you're thinking about ovulatory disturbances, so PCOS, and you're thinking about irregular cycles, and any signs of hyperandrogenism. And if she's on anticoagulation, you're thinking iatrogenic. Okay. In terms of your tests, then history examination, incredibly important to help you determine. And then your diagnostic tests, obviously excluding a pregnancy. We're thinking about, depending on what you're thinking, you may want to do swabs, thinking potentially kind of about PID picture. You want to do a full blood count and a coagulation profile. If you're thinking there's thyroid dysfunction, then you may want to do thyroid function tests. An ultrasound is really important. Mohammed was asking about, is it enough to diagnose adenomyosis with MRI? So adenomyosis, you wouldn't routinely do an MRI. The image I showed you was just a very nice image, but normally you would just do an ultrasound scan. And you would hope to see it on there. It doesn't always pick it up though, because remember, ultrasound is different to CTs and MRIs because it's dependent on the person performing the ultrasound. So an ultrasound done by a very junior sonographer will be very different to an ultrasound done by a very experienced consultant, for example. But it's different with CT and MRI, where the images don't change because they're done by a machine. So anyone can see them, but the images you get on ultrasound will depend on the user. So routinely just the ultrasound for adenomyosis, and we wouldn't normally do a biopsy because when you do a biopsy, you usually just do an endometrial biopsy, so that wouldn't show you adenomyosis, because they're within the myometrium. And then depending on what you're suspecting, what the ultrasound shows, you may want to then think about doing a hysteroscopy and potential laparoscopy for treatment. In terms of management, obviously in the acute situation, you do your ABCD. Stopping the bleeding, we use tranexamic acid. You would use 1 gram 4 times a day for a maximum usually of 5 days. We don't use it for a long period of time because there is an increased risk of developing a DVT with prolonged use. And progesterone therapy is important, and we can use that to help arrest bleeding. And we use norethistron. Usually we would think about 5 milligrams 3 times a day. You want to give that for 10 days. Okay, and then we want to think about the ongoing treatment. So is this a regular thing every month? And, do painkillers suffice? Does she need to have tranexamic acid every month just for the time she's bleeding? She can do. You then think about hormonal treatment. If she wants contraception as well, then you can think about giving the combined oral contraceptive pill. We have the Mirena coil, also known as the intrauterine system, IUS, progesterone-only pill. So there's lots of hormonal options depending on what's available. And then it's very hard to give generalized management, but with severe bleeding, there is the option potentially of thinking about GnRH analogs, which cause a temporary menopause. But of course, then women are at risk of the sequelae of menopause, so they need to have hormone replacement therapy. I'm not going to touch on this in detail at the moment in the interest of time. And then surgery is an option as well, depending on what the conditions are. So obviously for fibroids, if it's a submucosal fibroids within the endometrium, disrupting the endometrium, you can go in vaginally with with hysteroscopy and do what we call a TCRF, transcervical resection of the fibroid. The alternative is if it's a subserosal fibroid, we can go in abdominally with keyhole surgery or open surgery. And that way you can go in and do what we call a myomectomy, which is where we go in, find the fibroid, and then remove the fibroid. Often we can use a screw that we can put into the fibroid to help remove it. And then we need to close it up in layers to make sure there's no gaps left within the endometrium. There are lots of other options as well. There's something called uterine artery embolization, which is done if you have interventional radiology and they go in with vascular catheters and they find the vessel feeding the fibroid, and they can put in some particles there to block off and embolize that vessel. And then, of course, you have the option of hysterectomy as well, potentially, depending on the situation. Okay, so there's lots of different options, but it depends on what the condition is. But because we're focusing on emergencies, I won't delve into this too much. Okay, so thank you. I hope that was helpful for you guys. There is a workbook that's been made by one of my colleagues.